Coming up next on Arizona Horizon, Senate President Andy Biggs joins us in studio to discuss a number of things, including the governor's call to settle a budget. And the head of England's national healthcare system talks about government's role in healthcare. Those stories next on Arizona Horizon.
Arizona Horizon is made possible by contributions from the Friends of Arizona PBS, members of your PBS station. Thank you.
Good evening and welcome to Arizona Horizon. I'm Ted Simons. Retired Phoenix Police Sergeant Paul Penzone says he's running for Maricopa County Sheriff again. Penzone, a Democrat, lost to Sheriff Joe Arpaio 4 years ago, but plans to give it another shot. Penzone tells 12 News that when it comes to Arpaio, quote, "If you lose touch with what's going on in your organization, then you've overstayed your welcome. I think it's been more about keeping his job than doing his job." Penzone lost to Arpaio by 5 percentage points in 2012 and was outspent more than 8-1. And State Treasurer Jeff DeWitt tells the Arizona Republic that he will not seek re-election at the end of his term. DeWitt's only been in office for 18 months, but he says he's fed up with politics at the Capitol. DeWitt says his opposition to the governor's plan to use the state land trust to settle an education lawsuit has hampered his ability to work with the governor and the legislature. DeWitt says that politicians seem to, quote, "catch some sort of disease, and I never want to catch that disease." Governor Ducey's office says the governor wants the lawmakers to agree on a budget before sending over any more bills. Here now to talk about that and other legislative issues is Senate President Andy Biggs. Good to see you again.
Good to see you. Thanks for having me.
Thanks for being Governor. No more bills until the budget. My impression is the budget could even be flying around right now on a spreadsheet. How close are we?
Well, you know, there's all kinds of ideas, and the budget. There are spreadsheets that are circulating, and you know, I had hoped that we would be voting on one this week. We're probably not going to get there. Maybe next week, I'm hoping. But I'm told consistently that I'm an optimist, a cockeyed optimist. So.
Well, is the message from the governor that he's going to go ahead and veto any non-budget bills? Is that the message you're getting here?
No, I don't think so. I think he's just trying to send a signal that what he really wants is for people to focus on doing the work of the budget, which includes everything from small group meetings to one-on-one meetings to meetings with the House, meetings with between legislative bodies and with the governor's office. I think he's just trying to provide encouragement and stimulation.
Are there outstanding issues out there that still need to be resolved?
I would say so, yeah.
Can you give us a hint as to what they might be?
I can give you in broad terms. What happens is when there's not much money, most people realize there's not much money, and they tamp down on their expectations. They understand that you have to make adjustments. When there's a perception that there's some money, it's not so much. There's more spending desires. There's pent-up desire to spend, and so what we see happening is requests to spend typically are going to be far more than you've got in ongoing funding. So you have to determine what's ongoing, what's one time, what can we afford, what can't we afford.
Well, can Arizona afford kids care?
Good question. Is this just the one you thought was a favorite topic?
It's always your favorite topic, yeah.
Yeah, it always is. Look, here's the deal. With kids care, there's some things that most people forget about. We had kids care at one point. And when we had kids care, the federal government wasn't paying for everything. Now, they're telling you they're going to pay for everything now, but kids care is up for reauthorization in actually not too many more months. And when it comes up for reauthorization in fiscal year 2017, we don't know what CMS is going to do. We don't know what the federal government's going to do. And you're talking about a federal government that has a budget next year for somewhere like north of $3.3 trillion and the revenues somewhere south of $2.5 trillion. So you have almost $1 trillion deficit. So the question is, are they going to continue to fund all of these types of programs? And if they're not, then I hearken back to where we were last time we did kids care, and it came to a termination under Governor Brewer because we were spending tens upon millions of dollars every year that we just didn't have. And so that becomes a question. And people say, oh, it's free, we'll trigger up or something like that. But you know, supposedly many of these kids should have been taken care of under Obamacare, but they're not because Obamacare's been an utter failure. And then some of these children may be eligible under normal access or Medicaid.
Well, some would argue if Obamacare has been an utter failure, there is apparently a way for folks, the working poor, to not qualify for the better insurance, the needed insurance under Obamacare, and still be ineligible for access and Medicaid. There is a bill through 2017, no cost to Arizona, with triggers that if the federal government decides we're going to renege, we're going to mess around here, we're going to fool around, the triggers are into place, the state is off the hook, and we return to where we are right now. That bill is out there. If 47 out of 60 folks in the House said they liked that, they thought it was a good idea, comes to the Senate and you don't do anything with it. Why?
Well, Ted, the idea of triggers is an interesting concept that you put there. What does a trigger really do legislatively?
Well, a trigger is, from my impression, a trigger says if you don't do X, I pull the trigger and we return to where we were.
Right. Well, let's talk about the way it really works. What you do is you create a constituency of 30 to 50,000, could be as much as 50,000 people.
Right.
And now you pull the trigger to take them off? The answer is that's not going to happen. Nobody will pull that trigger. You can't pull the trigger. And it won't be automatic. They want to make it automatic, but it is this simple. You do a notwithstand bill, and now your trigger is unpulled. And the reason that you would do it, and some people haven't lived through this, and that's why it's good to have some experience. I lived through a scenario when we were flat busted as a state. Mm-hmm. We had a new governor who came in and said, I want you to cut $170 million out of social medicine spending. That's what she said. We proceeded to have those hearings, which were tragic, horrible hearings. Mm-hmm. And we didn't really want to do it, but we did it. What do you think happened? Those constituencies said, you can't cut the spending on us. The governor said, veto. She'd asked for us to make the cut, we made the cut, she vetoed it. And that's what happens with these types of issues. I mean, to simply say, I think it is overly simplistic to say, oh, we're just going to put a trigger on here and it just stops. Because it won't just stop because you've created a constituency.
Well, if you've created a constituency, if you've created a need, if you've created an outcry, doesn't that tell you that it's needed now?
No, I disagree, Ted. So what happens is you get somebody who writes repeatedly and assails me personally, and what she's saying is Biggs holds us up. But she has never examined nor revealed anything like I've just said. That you step into it, you walk into it, you've got some other things to take care of. The fact of the matter, Ted, is I could point to many things that people believe we need to do right now. I have people coming and they say, you know what, we need transportation infrastructure dollars desperately. And let's go ahead and put hundreds of millions of dollars there. The whole point is there are priorities and balances that have to be taken into account when you do this.
Shouldn't that then be heard?
Well, should every bill then be heard, Ted? Do you think
but we're not talking about every bill. We're talking about a bill that came over from the House, 47 out of 60. It's a Republican-sponsored bill. I mean, at least hear it.
No. So do you think every Republican-sponsored bill should be heard?
No, but I'm not talking about everyone. I'm talking about this one.
That's because it's the one you want to talk about.
Sure.
But so why don't we talk about every Republican-sponsored bill and say, okay, you know what? Because if that's your rationale.
But how many bills come over with that kind of support from the House that are never even heard in the Senate?
Well, more than you would think. More than you would think, because I'm not the only one who holds bills. Mm-hmm. Every committee chairman also has the prerogative to withhold a hearing. So let me give you an example of 4 bills right now that we're struggling to see if there's a way to make them work. There are 4 bills that came over 59-0. But you know why they came over 59-0? Because people said, well, we need Biggs to fix them. We need the Senate to fix them. And so we're going to go over there and see if we can fix them. Now, what's the rationale there? The rationale is they want someone to intervene. So you're saying put it up I'm saying I don't think we need to put it up necessarily.
You've also been quoted as saying that you don't support kids care.
I don't
and that's
support-
why you're not hearing it or putting it up.
I don't, no, that's not what the quote was. The quote was, I don't support kids care. The reason I don't support kids care, and then I iterated the reasons that I just went through with you.
Right.
So I don't support kids care. I don't support socialized medicine. I don't. I simply think that's wrong. I
So
think
30 to 50,000 kids are just out of luck?
no. I think that there are mechanisms in place that are actually providing health care for those children.
And they're not taking advantage of them. They don't know enough to take it. The families don't know enough to take advantage of them.
Well, let me ask you this question: what makes you think they're not taking advantage of them?
I don't know if they're taking advantage of them or not, but it
So
sounds like.
but you're
it's-
you're making a huge assumption to
So
to provide fuel to castigate me on an assumption that you don't have the information.
I'm
on.
not castigating you on this. I'm asking for your reasoning because I think a lot of people want to know.
Yeah.
I don't think people think that you're a bad guy and that you want
Oh
30
no,
to
you haven't heard the phone calls that come in.
You haven't heard the phone calls that come into me, so we can compare and
We
contrast.
could.
But 30 to 50,000 kids could be helped here, and I'm hearing a lot of procedural talk. I'm hearing a lot of ideological talk.
No,
but I'm
no.
not hearing about the 30 to 50,000 kids.
Let me explain to you again. Do we have the money to afford it when the federal government says no? Let me give you an example. The IDEA program. The IDEA program was supposed to be funded approximately, I think it was 60%. It's never been funded more than about 25%. Arizona spends millions upon millions of dollars a year. We go through and we prioritize. You're talking about a population that most likely qualifies under already existing access Medicaid rules. You're talking about a population that was supposed to be able to receive ACA care.
Right.
And so what you're saying is they're not getting it. Nobody really knows how accurate that is. Nobody's come through and said that what they say is, we'd like this to be taken care of. But if you were to look at uncompensated care at the hospitals and other medical care providers, they would tell you that they're providing much of this care. It's that simple.
So there aren't 30 to 50,000 kids.
I'm saying I don't know, and you're saying you don't know either.
Well, I don't know for sure, but I do know that there are 30 to 50,000 families out there that apparently are not covered by insurance that would be covered if this, and I'm not even talking about whether it passes or not. I'm just saying, why didn't you hear it?
Well, I think
Yeah, I know, you can't hear every bill, I understand.
No, it's beyond that. I mean, look, one of the jobs that a Senate president takes on is sometimes their members don't want something to be heard. And they're going to come to me and they're going to say, I can't do this. And if it goes on, it goes on. But the reality is, I take the beating. That's my job.
Was this one of those cases?
In some instances, yeah. I'm not the only one who opposes kids care.
So are you saying some folks that support it actually came to you behind the scenes and said, you know, I'm on record supporting this, but don't hear it?
It just may be that case, Ted.
Do you think that you are being unfairly maligned over this?
No, I think look, people can castigate me, they can say whatever they want to. I'm okay with that. That's the beauty of America. That is the beauty. But I do think that when people don't want to hear my side, or they don't want to investigate it. I mean, to be frank, Ted, there's a lot of what you said, and you've admitted you really don't know this issue.
What did I admit I don't know about the issue?
You don't know whether there's 30 to 50,000 children
It's been reported repeatedly that are you saying there aren't 30 to 50?
And I'm saying, yeah, I don't know.
Well, then you don't know either.
There you go.
So we're both sitting here, we don't know anything.
Right.
And we're not going to listen to the experts or those who do know.
Who are your experts? The newspaper reporters? I mean, that's what you're relying on. You said it's been reported.
Well, but children's health advocates are also, there's a Republican who's sponsoring the bill in the House. There
sure.
are 47 lawmakers over. Do they not know what they're talking about?
I'm just gonna say this very very humbly.
All right.
Maybe not.
Okay.
Maybe not. The point I'm trying to make to you, Ted, is I'm okay with people disagreeing with me. You disagree with me, obviously.
Not necessarily.
Well,
I'm
I think
trying
you
to
do.
get, I'm trying to get an answer.
You're disagreeing
I'm
with
trying to get an
me.
answer out of you. I'm seeing
Well,
common sense.
what
I'm
answer
seeing-
do you want from me?
I'm seeing common sense that
What
says we
answer?
don't have to pay. There is a trigger that if we do have to pay, we're out of it.
And I'm telling you that my experience says you can have all the triggers you want, but when you have a constituency, the triggers don't mean anything. That's my point. And people say, well, you know, they take your position. Well, there's a trigger, Andy. This just won't happen. And I say, hey, you know what? I've lived through it, and believe me, it happens. We blow through this stuff all the time.
We've run out of time.
You got to be kidding me.
We've
Ted.
run out of time. I didn't have a chance to ask about why you supported dark money. All right. It's good to see you. Thanks for
It's good to see you, Ted. Thanks.
Introducing Classical Arizona PBS, your classical music connection. On TV, listen to Classical Arizona PBS on digital channel 8.4. On the go, download the free Classical Arizona PBS app to stream performances. Find out about classical concerts and watch exclusive videos. Download the free Classical Arizona PBS app, then follow Classical Arizona PBS on Facebook and Twitter for news, photos, and events near you. Classical Arizona PBS, your classical music connection.
Most nations around the world have some kind of government-run national healthcare system, but the idea has yet to catch on here in the U.S. Joining us now to discuss whether or not healthcare systems should be nationalized is Sir Malcolm Grant, chairman of NHS England, and Dr. Dennis Cortese, emeritus president and CEO of the Mayo Clinic. Good to have you both here. Thanks for joining us. We appreciate it.
Great pleasure. You're welcome.
Should healthcare systems be nationalized?
I'm not sure about nationalized, but they certainly should be national. I think every nation that takes an interest in the health and the welfare of its population is doing something that all politicians aspire to do. And I think that a system that invests in the health of its population also invests in its economy. And to do that, and to have equity across a nation, it's critically important to have an overall strategy for healthcare.
Taking an interest, investing, but still, is it the best way to provide coverage?
Yeah, that's a very interesting point. The nationalness of a delivery system and of a health system in the United States could very well have two or three components. One is the strategic level. What are we trying to accomplish? And we've spoken to some presidents and other leaders nationally. They ask for that we should be getting what we pay for. Mm-hmm. We should be getting high value care, better outcomes, better safety, better service, lower cost. You've heard me say this many times. When you take the next level down and you begin to look at the strategy for that, we should be actually looking at our outcomes and how we're delivering care and changing it, supporting that with these other two issues, which is very much what Malcolm was getting at. One, should we have a national approach to insurance, which is what your question was. And the other is, should we have a national approach to the way care is delivered? I personally feel a national approach to insurance makes sense. It should be viewed that way. A model that I would prefer to see would be one that's like the Federal Employees Healthcare Plan. That is one with the government requiring people to have insurance, premium support for those who need it, and private insurance options so they have choice.
How does that compare to what's happening in England?
What's happening in England since 1948 has been a model in which insurance is quite marginalized. What we do is pool risk across the whole of the population by running the healthcare service on the basis of taxation. So the consequence of that is we end up spending about 8% of the nation's GDP on healthcare. And that, by the way, is almost exactly the equivalent of the tax-based contribution in the US towards the nation's healthcare. The other half of that, which brings the US up to about 17.4% of GDP, comes from private contributions. So our model is by no means perfect. Having a tax base gets mixed up with politics all the time, but at the same time, it does two things, I would say. It cuts out a lot of the complexity and overhead cost of running an insurance model. And secondly, it enables you to spread equity across the whole of the system. And the fundamental promise of the NHS is that everybody, every citizen, rich or poor, gets free healthcare at the point of clinical need.
When you see what's happening in England and you see what's happening in America, where do the twain meet?
Well, first, they're totally different countries
Yes.
in the sense, and the cultures are quite different. It would probably be, the meat would be somewhere closer to what some other European countries are doing for their national health scheme, healthcare scheme, particularly their health insurance scheme, which it would be, the examples would be the Netherlands, Germany, perhaps Switzerland, where they have much more involvement with the government overseeing, but the insurance is provided through private insurers. And that's very much what we have in the Federal Employees Plan. The alternative is a single payer,
Right.
like Medicare for All. But, and I'll stop and pass the ball back, but Medicare for All is not a single payer. We have to understand that Medicare covers with federal dollars through taxes as the primary payer. However, 90% of all people in Medicare, by the AARP's numbers, also have private insurance for their supplemental coverage for copays and deductibles, and another set of private insurance for their drug coverage. So even Medicare, 2 of the 3 coverages are private.
When you see what's happening in the U.S. and how healthcare, the debate, the changes, what do you think?
Well, I think the systems are very different, but actually, you know, the fundamental problems that we face are exactly the same. We've got an aging population. We've got, I think, 2 or 3 very serious health issues running through the population. Certainly with an aging population, one of these is dementia, which costs an increasing amount of investment to look after, and which requires us to bring healthcare and social care into the same basket, particularly for funding, which we're doing, I hope, increasingly in the UK. And the second issue we've got is obesity and type 2 diabetes flowing from that. And now these are issues over which actually the formal healthcare system is relatively marginally important. Much more importantly is our focus on public health and on prevention in the case of obesity, particularly with childhood obesity. The complexities of healthcare systems, I think, still require a lot of ironing out in both of our countries.
Right.
I have to say, you know, Den is a magnificent advocate for what you do in the US, for some of it. And I have to say, I just so profoundly believe in a uniform system, tax-based, pooling risk across the whole population, and founded on the premise of 1948 in place of fear, that the population should always have access to healthcare irrespective of insurance.
The idea of governments getting involved, especially in the United States, with political polarization as a possibility and right now a reality, the impact, the balance there, how do you work those? How do you work that dynamic?
It's extremely difficult, and it's compounded by an additional problem that both countries deal with. And that is that the payment models are based on fee-for-service and volumes we do for people. If we're going to deal with these long-term chronic illnesses, just the US and the UK, both countries are moving to new payment models. I'm very attuned to what they're doing there, where you begin to sort of bundle the amount of dollars that are available, and you have to come up with new models of care. So we need to have the politicians get out of micromanaging the way we practice, but manage the outcomes we're doing and change the way they're paying for care. And that's happening in the US. It's starting to change now.
It's starting to change, but will the big changes happen by way of a lurch or by way of a ramp up?
We had a lurch, unfortunately, without bipartisan support. And that was a major mistake that we did with the ACA, in my opinion. The ACA was put through without, this was major social legislation without bipartisan support. To me, that's politics 101. You don't do something like that.
But that goes back to my previous question.
I understand.
If things are so polarized, how
Right.
can you get bipartisan support?
Well, we had a little closer opportunity back in 2008, but you're exactly right. We need to start having a very good thought basis around the overarching national strategy for healthcare. This is how you start at the question, and I agree completely with Malcolm on that point. We need a national strategy.
We've got about 30 seconds left. As far as what's happening in England, will things gradually change at all? Will they develop? Are you pretty solid where you are?
I would say they're going to change in several respects. I mean, I think, frankly, the first one is that the practice of medicine worldwide is going to be transformed by new technologies.
Yes.
No time to develop that. But I think that secondly, in the UK, we will see changes along the line that Denny's been talking about, which is no longer paying for activity, but for paying for outcomes for patients. And thirdly, actually, we're going to move a bit from being a national service to being more regional. We've just last week launched a whole new program for Manchester. 3 million citizens, bringing together the local governments with the National Health Service to give that integrated model that includes social care alongside healthcare.
Wow. Great discussion. Very interesting. Good to have you both here. Thank you so much
A great
for joining
pleasure.
us. We
Thank you
appreciate
for
it.
the invitation.
You're welcome. Thank you.
Thank you.
And that is it for now. I'm Ted Simons. Thank you so much for joining us. You have a great evening.
Arizona Horizon is made possible by contributions from the Friends of Arizona PBS, members of your PBS station. Thank you.